You just did something extraordinary. You grew and birthed a human being. Your body went through changes more dramatic than most injuries medicine treats. Your bones shifted positions. Your ligaments stretched to several times their normal length. Your organs were displaced. Your abdomen muscles separated. Your pelvic floor stretched beyond what seems even possible. Your blood volume increased by 50%. This is massive psychological change. In terms of tissue stress and biomechanic impact, it's comparable to a major trauma injury. Professional athletes who tear an ACL gets 9 to 12 months of structured rehab. You get 6-week checkup. At that appointment, your doctor checks, did your uterus contract back down? Is your incision or tear healed? Are you bleeding normally? And do you have birth control? That takes about 10 to 15 minutes. Then you're cleared for normal activity, but your hips hurt. Your back hurts. You can't do a sit-up. You pee a little when you sneeze, and you ask, is this normal? Oh yeah, that's normal. Your body just went through a lot. Give it time. 6 months later, you're still in pain. Is this still normal? Some women take longer to recover. That's just how it is for some people. A year later, maybe 2 years later, still being told it's normal. Part of motherhood. Your body changed. That's life after kids. When did preventable dysfunction become normal? And why does medicine treat postpartum recovery so differently than any other physical trauma? Let's start with what actually happens at that 6 weeks postpartum checkup. You show up 6 weeks after giving birth. Maybe you bring the baby. Maybe someone's watching that. You're exhausted either way. You go into the exam room. You fill out a form, questions about bleeding, pain at incision and tear site, mood, birth control plan, breastfeeding. Then your OB comes in. They ask, how are you doing? How's the baby? How's the breastfeeding going? Then the physical exam. They palpate your abdomen, check if your uterus has contracted back down to normal size. By 6 weeks, it should be back to roughly pre-pregnancy size. If you had a C-section, they check your incision. Is it healed? Any signs of an infection? Looks good. If you have a vaginal delivery, maybe a brief pelvic exam, quick check of the cervix, maybe check for obvious prolapse, organs drop down. But often this is skipped if you're not reporting symptoms. That's it. That's the physical exam. What got checked? Uterus size, incision and tear healing, bleeding status, obvious complaints. What didn't get checked was your core muscle function, your pelvic floor coordination, your abdominal separation, usually not assessed, your hip mechanics, your pelvic alignment, movement patterns, strength, your stability during functional movement, pain with specific activities. Then the discussion. Everything looks good. You're healing well. You're cleared for exercise, intimacy, normal activity. Do you have any questions? You might mention your hips really hurt. My back is killing me. Or I can't do a sit-up. Or I like when I jump. Common responses would be like, that's normal. Your body went through a lot. Give it more time. Or try to do some gentle exercises. Walking is great. Maybe they'll say, you might want to see a physical therapist if it's really bothering you. Or how about some women just have these issues after pregnancy? It's part of the process. Your appointment ends. You're cleared. You leave. But let's put this into perspective. 9 months of progressive biomechanic changes, birth, hours of intense physical trauma and tissue stress, 6 weeks of initial healing, total professional assessment of recovery, 1 15-minute appointment checking if acute injuries healed. Compare this to an ACL reconstruction rehab. Injury affects one ligament in one joint. Immediate post-op. Structured protocol begins day 1. By week 1 and 2, multiple PT sessions, range of motion focus. Week 3 and 6 continues PT 2 to 3 times a week. Begin weight bearing progression. By month 2 and 3, strength building. 4 and 6, advanced strengthening. Return to activity progression. By month 6 and 9, sports specific training. Testing before full clearance. Total PT visits is between 40 to 60 sessions over 9 to 12 months. Objective testing before clearance. They get strength measurements, hop tests, movement quality assessments, return to sports readiness, 9 to 12 months of structured rehab for one ligament. We get 6 weeks. And if you're cleared for a body biomechanical trauma, the control is stark. The contrast is stark. So why 6 weeks? Where did this model come from? The 6 weeks postpartum checkup became standard in the 90s. At that time, medicine was primarily concerned with preventing postpartum hemorrhage, infection, uterine complications, and maternal death. These were real dangers. Maternal mortality was significantly higher. 6 weeks was chosen because by 6 weeks, the uterus has fully enfolded, contracted back down. Postpartum bleeding has typically stopped, and acute healing of incisions and tears is complete. The risk of serious infection has largely passed. This was about ensuring survival and preventing life-threatening complications. It was never about optimal function recovery, return to pre-pregnancy movement patterns, prevention of chronic pain, and restoration of core and pelvic floor function. Because in the 19th, women's long-term function wasn't medical priority. Women's roles were different. Expectations were different. Women weren't expected to return to a high-level physical activity, career with physical demands, or athletic pursuits. If women had chronic pain after childbirth, it was just accepted, part of life as a mother. There was no framework for addressing it beyond rest when you can, and that's just how it is. So let's fast forward to today. Women are returning to physically demanding careers. They're primary household managers, often sole child providers for a large portion of the day, expected to bounce back, wanting to return to exercise, sports, and active lifestyles, intimacy. The physical demand of women's bodies postpartum are completely different than the 1950s. But the medical model hasn't changed. We're still using the 1950s protocol designed to prevent maternal death, not designed for functional recovery, chronic pain prevention, or return to activity. And OBGYN training hasn't significantly expanded postpartum care protocols. So why not? Because of how medicine is soiled into specialties. OBGYN job is defined as managing pregnancy, delivering the baby safely, and ensuring immediate postpartum recovery from birth-related injuries and reproductive health. Not on their scope is long-term musculoskeletal function, movement pattern restoration, core rehabilitation, and chronic pain prevention. That would be orthopedic physical therapy and sports medicine, different department, different specialties. But those specialties aren't automatically involved in postpartum care unless the patient develops chronic pain months or years later, by which point it's much harder to address than it would have been in the early intervention. So nobody owns comprehensive postpartum function recovery. OBs do a 6-week check for complications. That's where the responsibility traditionally ends. And nobody else picks up unless the patient develops problems and seeks the help. By then, usually the patient is told, part of being mom, give it a little bit. So the patient waits a little bit. And by then, so if the US model is a 6-week checkup and you're fine, what do other countries do? Let's start with France. In France, every woman gets re-educational prenatal after childbirth. Translation, prenatal re-education, which means in practice, it's prescribed automatically after birth, not optional, not if you have problems, everyone gets it. 10 to 12 sessions of specialized pelvic floor physical therapy, starting around 6 to 8 weeks postpartum. Once acute healing is complete, covered 100% by National Health Insurance. What happens in these sessions? So session 1 to 2, comprehensive assessment, the pelvic floor strength and coordination, your abdominal diastasis recti measurement, core function testing, your movement pattern screening, and scar tissue mobility if you have a C-section. By session 3 to 12, you get active. rehabilitation, pelvic floor retraining, activate and coordination, core restoration progress, your movement pattern correction, strength building, and return to activity guidance. By session 13 to 20, if it's needed, advanced training, sport specific preparation, high impact activity preparation, and problem solving for persistent issues. This is standard care, expected. It's normalized. Do French women have some genetic advantage? Do they experience less birth trauma? No. They get preventative rehabilitation. Problems get caught early before they become chronic. Now let's go look over at the Netherlands. New moms get, I'm going to butcher it, but it's going to be Corazora. It's a unique postpartum care system. A trained maternity care specialist comes to your home for the first 8 to 10 days after birth, several hours per day. So what do? They monitor mother and baby's health. They help with breastfeeding. They teach newborn care, light housework and meal prep, check on mother's physical recovery. This includes how she's moving, any pain with walking, sitting, standing. Can she pick up the baby comfortably? Any urinary issues? How is her energy level? If they notice a red flag, immediate referral to either a physical therapist, pelvic floor specialist, a GP to follow up, covered by mandatory health insurance. After that period, it continue follow-up. Home visits by specialized nurses at 2 weeks, 4 weeks, 8 weeks. Physical recovery is part of each assessment. Physical therapy referral is common and done early, issues when they are identified. Germany has similar comprehensive postpartum care, which includes a midwife home visit up to 12-week postpartum, covered by insurance, up to 12 midwife visits in your first 12 weeks, including assessment by a physical recovery, movement function, core pelvic floor basics, return to activity guidance, easy referral pathway to a pelvic floor physical therapy, postpartum exercise program, and specialist if needed. Australia has improved its model significantly in recent years. Multiple postnatal checkup with your GP and maternal child health nurse, 1 to 2 weeks, 4 to 6 weeks, and 12 weeks. Includes basic physical screening and referral to women's health physiotherapist, equivalent to a U.S. pelvic floor physical therapy, often covered or subsidized by Medicare. The U.S. is the outlier. We are the wealthiest country on the list I just shared. We spend more money. We spend more on healthcare per capita than any other nation. We provide least comprehensive postpartum support. Why hasn't the U.S. adopted better postpartum care models? It's not because we don't know about these other models. American pelvic floor PT, OBGYN, and researchers know about the French and Dutch models. Many advocate for adopting similar approaches, but it hasn't happened at a system level. There's 4 main reasons. Insurance coverage. U.S. healthcare is primarily insurance-based, unlike many European systems. Insurance companies determine what covered based on medical necessity, their definition, cost-benefit analysis, their calculation, standard of care, what's currently standard. Preventative care doesn't fit this model well. Insurance logic. If the patient has acute problem, cover the treatment. If the patient doesn't have a problem yet, why pay for the treatment? To cover preventative care. Insurance wants proof it prevented costly problems later. For those studies take years and require funding. Meanwhile, no coverage. Circular. No coverage, no standard practice, no widespread data, no proof of benefits, no coverage. Breaking this cycle requires either government mandate, like other countries, or insurance companies voluntarily cover it despite lack of US-based data. Neither has happened. OBGYNs own pregnancy and immediate postpartum care. Physical therapists own rehabilitation. There's a gap between them. Who owns comprehensive postpartum rehab? Nobody, clearly. OBs could expand their scope to include more comprehensive postpartum functional assessment. But that would also require additional training they didn't receive, more time per patient not reimbursed. Coordinating with PT is extra work. PT could get involved early and more proactively, but that requires automatic referral from your OB, insurance coverage, and patient awareness that this is even needed. Changing this requires professional organization coordinating, scope of practice discussion, training updates, reimbursement changes, standard care evolution. This is slow and politically complicated. In American culture, there is a strong narrative of maternal sacrifices and suffering. Bounce back culture, pressure to quickly return to pre-pregnancy body and function, but simultaneously, normalization of permanent dysfunction. Mom bod, that's just mom life. Bodies change. Both narratives are problematic. One creates unrealistic expectations without the support. The other normalizes preventable dysfunction. Neither recognizes that with proper rehabilitation, function can be restored without permanent pain or limitation. But it requires intervention and time. There's a cultural acceptance that mothers just suffer, sacrifice their bodies, and deal with it. This is questioned enough as a systematic level. In France, Netherlands, Germany, there's a cultural belief that mother recovery matters. Investment in postpartum care is worthwhile. Society owes mothers support beyond just making sure they don't die. US culture is different, more individualistic. You choose to have a baby, figure it out. This culture difference affects policies, priorities, and health care structures. Medicine priorities based on severity. Life-threatening conditions get attention and resources. Chronic pain and functional limitations, not urgent, not life-threatening, and low priority. But quality of life matters. Chronic pain affects your mental health, your ability to parent effectively, relationship with your partner, return to work, physical activity and health, and overall well-being. These are significant impacts, but they are hard to quantify in the way medicine and insurance can't easily put a dollar value on mother who can pick up her child without pain or women who can return to running. So it doesn't get prioritized in policy or coverage decisions. So when your doctor says your postpartum pain is normal, what do they really or actually mean? They're usually using normal to mean one of these things. A lot of women experience this, so it's statistically normal. But common doesn't mean optimal or inevitable. Example, so you got tooth decay used to be normal. Most people had cavities. That didn't mean it wasn't optimal or unavoidable. Preventative dentistry, regular cleaning, education. The same could be true to postpartum dysfunction with preventative rehabilitation. The pain is not indicating something life-threatening, so it's normal. Medical training heavily emphasizes ruling out serious pathology. If it's not dangerous, it's considered fine, normal, not urgent. But not dangerous doesn't mean acceptable or doesn't need treatment. Your body went through major trauma. Of course, there are consequences. That's normal. This is particularly true. Pregnancy is major biomechanical stress. Some consequences are expected, but the question is which consequences are inevitable and which is preventable. After surgery, you expect some pain during healing, temporary limitation, and need for rehab. You don't expect chronic pain for years later, permanent functional limitation, and no rehab offered. The same should apply postpartum. Expected and temporary. Acute pain from tissue healing, 6 to 12 weeks. Temporary weakness, initial limitation, and fatigue, not inevitable, should be addressed. Pain persists beyond 3 to 6 months. Permanent weakness, chronic function limitation, ongoing issues, chronic instability, but often most categories are called normal without distinction. Sometimes normal means this isn't something I can help with in my scope of practice, and I don't know where to refer you, so I'm calling it normal. OB at 6 weeks. Hip pain isn't my specialty. It's not a pregnancy complication, so it's normal postpartum stuff. This implies you should just accept it, when actually it needs a different specialist, one who understands postpartum biomechanics. But those referral pathways often don't exist in standard practice. What's normal should mean postpartum context. Normal recovery with appropriate support and rehab includes some expected temporary changes, but should not include chronic pain, significant function limitation, or permanent dysfunction. That's a very different standard than what's called normal. So what happens when we call preventative dysfunction normal? Women don't seek help because they think it's just how it is. Years pass with dysfunction becoming more entrenched. Problems that could have been fixed in weeks or months became chronic patterns that take much longer to address. Quality of life impact, can't exercise, leading into weight gain, cardiovascular health decline, mental health is impact, can't play with your kids the way they want, affects confidence and identity as a parent. The sexual function issues strain intimate relationships. Physical limitations affect career choices and advancements. Chronic pain contributes to depression and anxiety. These impacts compound over time. Health costs, years of doctor's visits trying to find answers, multiple rounds of physical therapy that it doesn't even address the root cause, long-term pain medication, eventually sometimes surgery that might have been prevented this whole darn time. All more expensive than earlier comprehensive postpartum rehab would have ever been. Economic impact, women leaving workforces or reducing hours due to chronic pain, reduced productivity when working in pain, long-term careers, trajectory impacts, social impacts, normalizing maternal suffering makes it harder to advocate for change. The next generation of women expect the same. The cycle continues, all because we called preventative dysfunction normal. It's not normal. It's common because the system hasn't updated its postpartum care model since the 1950s. And we know better now. We have the knowledge to prevent postpartum dysfunction. We have the rehab techniques. Other countries prove these approaches work, but we haven't implemented them as standard care in the US because the insurance structures, because of medical specialization boundaries, because of the culture acceptance or maternal suffering, because it's not immediately life-threatening. So normal becomes a way to avoid addressing a sick failure. The postpartum care model fails women, then calls failure normal, but common doesn't mean inevitable. Preventable shouldn't be called normal.